Thank you, Mr. Chairman. I would, and I welcome the Chairman in your testimony here today. Just to pick up on the line of questioning that Mr. Pomeroy was just on, I truly believe that one of the keys to any health care reform that we do around here isn't just dealing with coverage, but also linking costs with the quality of care that exists out there. Now, MedPAC has, in this report and in previous reports too, kind of touched upon it, but in a glancing sort of way when you look at the regional variations with the quality of health care that's being performed out there. What I want to ask you about is your thoughts on where we go forward with comparative effectiveness research, evidence-based research, and the role and the importance that that's going to play in any health care reform proposal. I mean, just today I think I read a report online that Consumer Reports now will be releasing a list of drugs that they recommend based on comparative effectiveness research. Medicaid programs from various states have utilized this in order to reduce costs. Private health plans, too, are looking at it. But I want to get your reaction or MedPAC's perspective on the role that comparative effectiveness is going to play with health care reform and potential cost savings that doesn't jeopardize the quality of care at the end of the day.
Yeah. Well, we think comparative effectiveness research is a critical piece of healthcare reform. Information about what works is essential for physicians and patients as well as for public and private insurers. The private marketplace has not and will not produce that research in adequate amounts. And so a public role in financing that research is essential in our view. Comparative effectiveness research is one of the few pieces of what's been labeled healthcare reform that has the potential, at least, to affect the long-term rate of increase in costs. The long-term rate of increase is heavily influenced by the way new technology comes into the system and how it diffuses through the system. And too often right now, the door is wide open to new technology. It's not carefully evaluated before the fact or even after the fact, and it just spreads. And it's used in cases where it may be very expensive but not all that effective. So we need research to make better decisions. I would make one last point. MedPAC's view is that the use of that information ought to be decentralized. We don't envision, one federal bureaucracy saying, here's the right answer for every question in medical care. We think that the use ought to be decentralized, physicians and patients, private insurers, public insurers, all acting independently, making the best judgments they can.
Mr. Hackbarth, let me ask you this. Obviously, there have been some concerns being raised already, and we had a little bit of that debate in the context of the Recovery and the Investment Act, where $1.1 billion was allotted in that for comparative effectiveness, and it'll be going to the Healthcare Research and Quality Agency, NIH, HHS, to kind of disperse it and get these studies in place. But how do you address the concern that some might have that this is only going to lead to rationing, this is only going to be about cost and not quality outcomes, and especially concerns being raised within the pharmaceutical industry and the medical technology manufacturers right now that are apparently very scared on how this information will be used?
Right. Well, what we need is information on effectiveness. Set aside cost for a second. We need better information about what works. And in our view, we're not going to get that unless we make this sort of public investment in the research. I can sympathize. I think we can all sympathize with people who are concerned about the potential for rationing. We can all envision ourselves as the patient or a loved one being the patient. And in that case, of course, we want the best possible care, damn the cost. That's how we would all act as individuals. But we're all also taxpayers. We're all also premium payers to private health plans. And from my perspective, we're also all parents or grandparents. And we've got a next generation or two to worry about. So as we think about this sort of investment, we shouldn't just put on the patient hat or potential patient hat and say, oh, all decisions ought to reflect that. We need to reflect the patient perspective, the taxpayer perspective, and the parent perspective, protecting the future generations.
So you think establishing the research that shows you the best outcomes, evidence-based, presenting that information to patients and doctors, that these are rational actors and they will make decisions accordingly?
Yes. Just to give one example, Tom Dean, a physician on the commission from South Dakota. As a practicing physician, he wants this information. He wants better information about what works so he can do a better job for his patients.
Great. Thank you.
That's the most basic level.
Thank you, Mr. Chairman.